I'm Laura Vander Molen. We're a small enough group, so if anyone really has any questions, and this is most of my staff, so please feel free to ask any questions, interrupt me. This doesn't have to be super formal. But this is about how we chose to incorporate students into our clinic. And the introduction, so this is just kind of what we're going to go through. I'll introduce myself in a minute, give you a little bit of background about what size clinic we are to see if that helps you. Fundraising and grants are the main way we get our money because we see a lot of underinsured. And then why we need data, why we use students and volunteers, and then some examples of my good efforts and some of my failures and what we've kind of learned so far. So I'm Laura Vander Molen. I am boarded in internal medicine. I trained IMPs. I came to Exalta Health after spending a year in South America, and I graduated from Kirksville College of Osteopathic Medicine. Did my Med-Peds residency in Grand Rapids and then ended up staying there. Our clinic is called Exalta Health. We're motivated by wanting wellness for all people, regardless of their zip code, their income, or their socioeconomic background. This comes out of our Christian faith, motivated by God's love. We work hard to give, it just went on its own, to provide accessible, quality health care that promotes wellness. That's been one of my goals, is to really try to give the best health care that we can. We see a large underinsured and refugee population. So this is kind of our history. We started way back in 1996. I came in around 2001, so I've been there for about 23 years, 22 years. We added dental services relatively early on, behavioral health, and then one of the things we're missing is spiritual health we added. We changed our name to Exalta. We were called Health Intervention Services, or HIS. We care for a large Hispanic population. That's really not an easy name for them. So we changed it to Exalta, trying to think about how we're exalting Christ and exalting people's health. So that was done in 2017. Our main diagnoses are diabetes, hypertension, anxiety and depression. Diabetes is one of the ones we can get a lot of grant funding for. So we've started different diabetic programs through the years. And so some of this, when you see the programs, you'll see the diabetes theme. And now we're in 2024. We're hoping to do a little bit more in the neighborhood in our community. So we have around 2,593 unique patients. Last year we saw 9,000 visits. Most of them are underemployed or unemployed. 50% fall below the poverty line. 60 to 65 have no insurance. These are the services that we provide. We have myself as a staff physician. Our other staff physician is Chris Shoemaker. We have volunteers for GYN, general surgery, urgent care, and then some of these other are specialists that we can refer to. Our dental services include dental hygiene, dental exams, root canals. We have a volunteer, he loves doing root canals, so we call them therapeutic root canals for him. So I don't know if it is for the patients or not, but he comes in. We have an oral surgeon who comes in and sees patients. Behavioral health was a blessing to have, and our social worker is up here. As you know, with the population we serve, it's not just their physical health, it's everything around them, all the social determinants of health. We have lots of anxiety and depression, and so being able to have a social worker see patients with us has been a huge help. Spiritual care. Sometimes when you start as a Christian clinic, we've always had a chaplain, but we didn't want that to be just a side thing. We wanted it really available to our patients. So as a primary care clinic, we do have chaplaincy. We have 92 volunteers work hours. We have about 115 volunteers that come in that are current. We have about 300 of them coming in for hours each month. So fundraising, an average cost to our visit is $160. Our goal is to raise about $1.7 million for this fiscal year. We get most of it through private donations. The other ones is through grants. And if anyone knows how to turn off the automatic timer, it's just, like the slides just keep going. That's okay. All right, so we have a passion for learners. So we have Calvin nursing students that come and do their community nursing program in our building. They're there Tuesdays and Wednesdays. We have MSU, Michigan State University, first-year students who come in and act as MAs. And then we have our NP and PA students that will do their rotations with us. And on the dental side, we have GRCC, which is another local school, the community college and Ferris State that bring in dental hygiene students. So I kid around that, students are awesome because they are computer savvy. You should have seen me at the very beginning because my computer didn't connect and I was panicked, and luckily there's young people who know how to fix things. Many of their classes, many of their programs require that they do a project, especially DNP students, and they need data. And I kid around that they're free labor, but in some ways they can increase our capacity, and we feel like we've been able to give them opportunities, so it works both ways. And I would say the other key thing that I don't have on the slide is I'm passionate about getting students involved in faith-based clinics early on, because I feel like it's my succession plan when I get old. And we actually have had students come back in. So I really think this is the time to get people to think about medicine in a different way. So what have we learned? My unsuccessful models have been when we've had really short placements. Unclear goals that many times were honestly from me. Poor oversight from the teaching universities or schools. The other one was poor communication of who we are and being faith-based, and the different universities sometimes are not, some of the students were not faith-based or not aligning with us, so that was a little difficult. Specific to grants, I think sometimes when you have a student or some help, you kind of want to get everything you possibly can done, and I picked too big of topics or too big of ideas to do, and not clear goals. So what's worked really well is our GVSU nurse practitioner students in particular are probably our best. They spend a whole year with us. So half of their year is them doing their rotation. So they really get to know us well. They're in the clinic, they're seeing our patients, they're starting to understand some of the problems that you have seeing underinsured or non-insured patients. They have a clear understanding of who we are before they even come in. We started interviewing them and them interviewing us. We said, no, you actually need to come into the clinic and see who we are, see our mission statement, see our vision statement, so that you're really aware of who you're working with. And then the other half of the year, they do their DMP project, which is supervised by one of their professors. They have to understand who we are treating. And then for me, for the grants, I needed to learn to be clear, concise, and have measurable goals. So here's the experience of our NPs. We had our first student in 2016, and then we've had one. We had a little break during COVID, and then since then we've had one pretty much every year. The first one, the safety net, this was one that I was like, oh my gosh, I got a student. We're going to do everything, So I had diabetics. I was going to do, make a dashboard that followed everything. And, we were going to have their foot checks on it, their hemoglobin A1C, their microalbumins, all the meds that they took. And it was, the student did an amazing job, but it was one of the ones that when she left, we didn't really keep up anything that we had started because it was just too big. So I have a picture of my, look at that page. I mean, it's a dream dashboard. And now with this was, we were kind of in between EMRs, what they could do or not, but it just didn't get done. But it was a learning curve, learned for me. The second one, this student and I sat down, and by that time I was a little gun shy of what I should do next. And with our patients, with the next two, our anxiety and depression, I'm a passionate screener, so I love PHQ-9s and 2s and GADs, and I like ACEs on new patients. And so we kind of took a step back, and this student said, why don't I just work on getting your screenings into how you're going to see your patients? And this one was, we still actually do this. So it might sound like a lot, but because we have so many volunteers, we actually do screenings pretty much on any established visit if it's not urgent. And that way we make sure, because every so often a volunteer is going to forget, so we make sure that we're getting one every couple months, usually 6 months to a year. Okay? And we integrated it right into that MA role. So we actually made cards that when people roomed, they had a little box that said, do the PHQ 2 or 9, GAD 7, and you're on COPE, which is for alcohol and drug abuse. So, and then the other thing we were really lucky for, and this is the other thing that we've run into trouble in the past, is our EMR could actually, not only could you put the right into our EMR, but they finally, Athena, who's our EMR group, you can actually follow these over time. So every time they put in a GAD score or a PHQ-9, you can follow those. So it was actually super nice for data, because if we are treating for someone for depression, we can actually look at their trend of their PHQ-9s and see, hey, with their medicine, they're actually way down to a 6. When they first came into us, they were super high. So, and then the other thing the nurse practitioner student showed in her data was that we were finally getting the data that we wanted. And I actually think I skipped a slide. Data for us is super important because of our grants. We're always being asked to report. You know, everything you do, you have to prove that you're doing it by some type of data. And so we actually had a grant on that one that was basically saying that we were going to increase our screening for depression and anxiety. This next one, this nutritional health screen, it was actually very well defined. This student came in for a very short time, and she did a chart review where she got this different information and then passed it to an AmeriCorps worker who would then call patients and make sure they had what they needed. It was very helpful, but it didn't necessarily change anything we did as a staff. Except for it started us to really think about readiness for change, which has been, so this is kind of what they looked at and what we were hoping to increase. So you can see at the bottom the tier 1, 2, and 3. This was the start of my aha moment that when I had diabetic patients that were non-compliant, and their hemoglobin A1Cs were like 14, I would make my nurse go see them and say, can you make them want to get their hemoglobin A1C down? And I say that in jest, but some of that was true, because I would get frustrated, or I'd say, Allison, what can you do? Can we do motivational interview? Can we move them along? And so I started to realize that a lot of effort was being put into patients who might not be ready to change. And that doesn't mean you don't want to take care of them well, but you don't want to get frustrated, and you want it to match what you can actually do for them. So we started doing readiness for change scores on our patients who have hemoglobin A1Cs greater than 9 before we would put them into some of our specialty stuff. And so that's kind of, so this is the beginning of this idea in 2022, what I just talked to you about we ended up looking at our diabetics and seeing that some of them not coming in the amount of times they were supposed to with their hemoglobin A1Cs being so high. And although we felt like we were educating, we didn't have a standard education thing that we were going to give specifically to our diabetics. So this is not with the student. We as a staff set up, okay, let's make 4 types of diabetic visits. We'll standardize what we're going to get on those 4 visits. If they're uncontrolled, they'll get hemoglobin A1Cs. On the first quarter, they'll get a book, a book about general diabetic information. The second book will be about self-testing. We picked, we didn't know exactly what that education piece was going to be, but we knew we wanted to set it up much more in a standard way. And then they would get readiness for change twice a year, so that hopefully as they started to come more regularly, even the ones who weren't initially interested, as they got more information and as we continued to talk to them about, hey, is there something that could help you be more interested in controlling your diabetes, that eventually we would get people who would say, yeah, I'm ready to do it. We also developed a lifestyle page that would have all the things that you can personally do to help control your diabetes, monitoring your sugars, exercise, taking your medicine, sleeping well, all those things, diet, exercise, and we would give that to the patient and say, here are the things that if you can look at, and when you're ready in any one of these areas, we'll set you up with one of our staff to be a coach. So the nurse practitioner took this huge idea and she said, I'll do this piece. I will help you develop what educational information I think you should hand out for each 4 of those. And with our nursing staff, we needed to find something that was bilingual. And so we ended up finding, I believe, they're the American Heart Association. I can't remember who we finally went with, but it was, we could have, they came in English and in Spanish. There's actually probably 6 books, but we picked these 4, and we give it to the patient every time they come in. And I'm amazed. It sounds kind of crazy because it might sound like you're giving the same information, but I think, again, you don't know when that patient is ready to actually hear it. So again, this is how they have to have so they have to have significant disease. We didn't necessarily want to be coaching the patients who had hemoglobin A1Cs of 7, because for us that's really well controlled. We have our population, our hemoglobin A1Cs can be pretty high. So they had to be 9 or higher, and then for the readiness for change, they had to score at least a 4 or a 5, which meant they were willing and ready to do it. And then if they scored below 3, we would still see them at their regular intervals and continue to engage them to see if they were ready to change. If they qualified for the coaching, or it's not true care management, but more coaching, they would get bi-weekly phone calls from one of our staff for the first month. So how's it going? You checked that you wanted to eat more healthy, and just helped with the different things like that. And then after that, they got monthly phone calls to see how they were doing. The 2023, so the 2022 and 23, we kind of combined those. So the first student helped us find the educational pieces to give to the students. The next year, we worked on what our coaching was going to look like to standardize the coaching that was going to be given by our staff members, because we had different levels of staff ability. We had our RN, our MA, our social worker, and so we wanted to be able to say, okay, let's all make sure we're going to give similar information so that there's no patient who's hearing one thing and then something different from someone else. So that's what we did. This year, so again, with diabetes being such a big issue in our world, retinal screening is something that we just weren't getting done. If you looked at our metrics for retinal screenings, it was really tough. Our patients, again, being non-insured, we were either trying to send them to an optometrist in the community, ophthalmologist in the community, or we had one volunteer optometrist that we would try to make sure as many patients could fit on their schedule as we could. And it was just it was hard for me because, again, our goal is to give the best care. And we know diabetics need their retinal screening. So we started looking into the optical coherence tomography cameras, which are retinal cameras. That can actually now, you can find it in data, can be used for retinal screening. And so our new nurse practitioner, Henry, who's with us, the other nice thing about this is for their projects for their school, they have to do a lot of literature research. So when we talked about this as an idea, he was able to send me all sorts of literature that I could actually read and decide that, yes, I'm actually correct. This could be used for screening. So then we also had our volunteer optometrist weigh in. And, he's the expert on retinal cameras. I am not. So we had our optometrist help us decide which camera we should try to obtain, and we got grant money to buy the camera. So the nurse practitioner's project now is setting up how we're going to put this in with our patient flow. And the retinal cameras are actually very easy to use, and it's actually very quick. So our goal is, because initially then it was still the same issue. We would schedule with him, he would do the retinal camera, and then he would still do an exam. And our goal is that our MAs and our nurses, and at least some of our volunteers, will actually learn how to use the OCT. And so when a patient comes in for that diabetic visit, if we realize they haven't had a screen, they go right back, have their retinal pictures taken, and then that gets sent to the optometrist. And then he tells me, he sends me a note in the EMR, this patient's good till next year, this patient I should see, this patient you need to go send to the retinal specialist after I see him. And so we've increased our numbers of screening. And I think our staff, they don't seem to be too bothered when I say, hey, can you run and get an OCT picture? So I think it's pretty exciting for me because I think for the first year we may have a really pretty good percent of our diabetics have their retinal screen. But this is helpful to me because anytime you do this, you need someone thinking through the steps, and you needed someone who could train the staff and just help us with the flow. And it sounds stupid, but even with the EMRs, where's that information going to go? And then for me, for the grants, is it reportable? Can I actually get to that information in the EMR and be able to send back to our funders, hey, last year we had 20 people get their screens, and this year we've already had over 60 OCTs done on patients. So that's all part of trying to get funding for us. So we're measuring how many OCTs we did, the number of retinopathy we find, and the number of referrals. So I think you guys are kind of lucky because I'm going to be done early. But so again, the summary, using student well, the longer placement's really helpful. My own feeling about students, and partly why we got to this, was we were getting burned out with having students who wanted to come for shadowing or for really short times, and you just felt like you were putting a lot in, and we were not, and not that you have to receive every time, but it was starting to even just burn us out because you would have someone want to just shadow. So this has been really helpful. Students who know the clinical population and patients well, grants that have measurable results that are clear and concise, and then implementation that can be continued on once that student leaves. You constantly have to be thinking, if I do this, who's going to do it once that student is gone? Does my staff really have capacity to do one more thing? Or what would need to change so that we can do that? I really enjoy working with the students. It's forced me to kind of develop my own skills. I was never going to be a grant writer, and I luckily don't have to write them all, but thinking about what can be measured, what we want to try to get money for, that's helped me continue to just try to improve some of those skills. And, you know, on the big picture, again, for me, having students be able to see a Christian clinic trying to give great care, a lot of them, you know, hadn't thought through how difficult it is to give care to non-insured and underinsured. So it opens their eyes to different needs. And it also, they realize some of the resiliency and just the specialness of our own patient population. So that is my presentation. I'd be willing to answer any questions. Yeah. I have only they help us think through what we might be able to measure and collecting the data. But the staff and myself and the fund developer actually write the grant. I'm not sure I would use the students. In writing the grants, you have to know so much detail of the clinic. Now their DMP projects they have to do a whole SWOT analysis of the clinic. So I've seen 5 SWOT analysis of what my strengths and weaknesses are of the clinic. I always enjoy that. I'm like, but so they get us a lot of information that I have used because all their DMP projects, we get copies of. So it's really helpful information, but I wouldn't say that I've thought about having them actually involved in the writing part. Yeah.
Could you speak into the process of recruiting the students to get involved in these projects?
So this one was pretty nice in that one of our board members at the clinic at the time, she's no longer a board member, is one of the professors at the DMP project. And so they needed placements for their NP students. And as I said before, when she presented it to me, we had a lot of, at that point, we had lots of, everybody needs hours and clinical time. And so I was like, I got to back off a little bit because my staff is saying to me, not another student if they're only going to be here, so long. So when she came to me with this project, she said, no, I really think this will be helpful if you think about specific data that you need. And it really has been very helpful. We're lucky in Grand Rapids. So those students are through the DMP project with Grand Valley. Our Michigan State students, they actually have a unique program. Their first-year med students have to act as MAs in a local clinic 2 days a week or 2 half days. So that's another one that was an easy yes to us. Now because it's helpful to us, they help our capacity, but they're also in with patients. And if we see something interesting, we're like, hey, come on in. So they actually do shadow and get to see a lot, but they're also just rooming patients. So it's a very cool program. The other thing we have is if students want to volunteer, we say yes to them, but they have to commit to a certain time period. And then, generally, we used to train a lot of students. Now we'll say, hey, you either have to have your EMT, a CNA, med tech, something so that we're not training every student who wants to come in and get hours, how to take a blood pressure, pulse, and all that. So, Lee, is it how much time do we require our students to give us? Yep. So it's kind of semester by semester we let them do it. But if they're going to start, we really say, make sure your semester's okay that you can give us this much time. We've done it a few times now where we've actually had a student do a gap year between med school, and actually, in general, we've employed them as MAs. And many times they've helped a lot with, we had one medical student during COVID. We had a unique opportunity to do COVID testing through MSU, through their research department. And so the MA, who was also in her gap year, she actually helped us document all the data for that. So that because that was kind of above and beyond what we were just normally doing in the clinic. And again, like I said, pre-med students, they're in general very bright and very computer savvy, and I think she really enjoyed the opportunity. And so it was a research process, so she learned about consenting patients and a lot of good information, collecting specimens, how we had to transport it. So, and we have one of our MAs that we have now, he's finishing his senior year, and then he'll be with us for a year. And then we will train, the ones we employ like that, we will train to be an MA. So like the previous one, we taught her how to draw blood, do lab things. So, yeah. Yeah. So for the ones who are just going to volunteer as MAs, it's more of orientation to a clinic, bloodborne pathogens, again, who we are, why we do what we do, professionalism, different things. So a lot of it just around, and then our process for rooming. They also have to learn our EMR. So it's more of some of those just practical stuff that they need to know, how to use our specific glucometers, how to use our blood pressure cuff, mainly our rooming practices, how to clean a room well, all that.
And Andrea is our
nurse clinical coordinator, so she does a lot of that training.
So that she'll kind of sign off on their competency and capacity to
Yeah.
do all of this.
We have a sheet that they have to have everything checked off on. And for any of our MAs, they come in and they have to do 3 shadows before they can be on their own. So the first shadow, they literally just watch people being roomed. The second one, maybe they'll do a few of the things. The third one, they try to do it, but they have someone with them at all times so that if they have a problem, they're not alone. And then after that, they can start with their own, independent shifts. So we try not to have anyone just thrown in. But yeah, we try to be intentional with their training. Anything else? Yeah.
How do you come up with different ideas for projects for these students to do? Because the students are not coming up with ideas for our clinic, right? But I guess how do you come up with these
So,
future projects?
yeah. So again, because diabetes is such a big deal for us to be able to get grants, and my goal is to try to really get my patients up to speed with any private practice with their measurable data. A lot of it, and we have a funder, we have a hospital that, Healthier Communities, who's given us quite a bit of money to help with our diabetes care. I just keep trying to think of if I could, I just dream about it, retinal screenings are so low in our clinic. What could we do? What could we do? For the PHQ-9 and GADS, it was, I know there's, without doing any screening, that was one of our top diagnoses. So what does that tell you? You're probably missing a lot because you already have it so high and we're not doing anything to actually look for it. So that was my passion for GAD7 and PHQ-9s. I strongly believe in ACEs. That's the adverse childhood experiences. My staff will laugh at me. I'm a terrible abbreviation person. So they kill me. So anyways, but that one, we know that if people have a score greater than 3, they're going to have more chronic illnesses and more risk for health disease, mental health, and substance abuse. So don't I want to know that? So that was, we started doing ACEs on our first-time patients, and then we actually do try to talk to them about it, about some of the different things we know we can help, and we try to talk to them about it as, hey, this is something that is not necessarily your fault or anything that you did, but stuff has happened in your life that may affect your health care, and we want to be aware of that because it puts you at greater risk. So I think, so a lot of it's just me dreaming, I know like already you start to think, okay, what will be next? What can we do better?